But can you tell us a bit about what you do now?
What I do now, like the nonprofit in my writing. So I started my nonprofit in 2016, the end of 2016. That's when we incorporated and kind of acted on this idea that we had. My co-founder, Beth, is paraplegic. And I met her through the National Sports Center for the Disabled through one of her coaches, because I met the coach at a shoe store, and I just started talking to him about pain, because apparently I do that. I just talk to people about pain wherever I am. And he said, I have an athlete I want you to meet. And he introduced me to Beth, who had just had a surgery called DRES, dorsal root entry zone lesioning, where they go in, they sever the sensory nerves, and that was supposed to fix her pain. And she had spent a long time making that decision because she knew she was going to become more paralyzed after it. So had the surgery, became more paralyzed by almost like 6 inches. So she went from pelvis up to lower rib cage, and her pain didn't go away. And actually became worse, and her pain level rose. So when I met her, she was in a very dark kind of place. And I started fire hosing her with pain science and all the stuff that I had learned and everything that had helped me. Completely overwhelmed her with information, but she was receptive to it, and she stuck around, thankfully. And we just started meeting, every week, a couple times a week. And the first thing she said was, why hasn't anyone told me any of this information before? And this was, over 5 years into her experience. She'd had 5 surgeries, I think, at that point. And all she'd ever been given were opioids, gabapentin, stuff like that for her pain. When I was in school, prior to meeting Beth, I just remember thinking all the time as I was coming up with papers and reading stuff, I'm like, why didn't anyone tell me this? Like, I saw so many clinicians. Why has nobody shared any of this type of understanding of pain with me and the things that I could do? Because for me, learning the pain science was so empowering. Like, it was validating because it made this complex pain experience that I had seem real. It was legit, and there was biological stuff underlying it. It wasn't just all in my head, and it made sense then that my imaging was okay after my surgery, but I still had pain. So it was validating, and it was also empowering. So I'm like, there's things I can do to change my experience, and then gradually over time started doing that. And at first my pain didn't go down, but my life got so much bigger because I no longer felt like I had to wait for pain to be gone to get back to living. And that was so important. So it was like my pain stayed the same, but the life around that pain got bigger and bigger and bigger. So sharing that with Beth, and then she did the same thing. Her pain levels didn't go down, but we had very small goals for her at first, like going out with friends once a week was a big thing for her. And I think that people don't realize how limited lives become in chronic pain, that was her first goal, was just to be able to go out with friends again, to meet for coffee. That's it, because her whole life was just in bed in pain at that point. So that whole idea of making life bigger, and we talked about like how could we give that information and that empowerment to other people? How can we, why didn't anyone tell me this sooner thing, how can we get people that information sooner? So then we started throwing around ideas of like doing retreats for women living with chronic pain, and just having women come together in a cabin in the mountains, because it's beautiful and the mountains have been healing for both of us. And we'll talk about pain science and share stories, and then practice, some living well strategies. So that idea we started throwing around January of 2016. That summer we researched how to become a nonprofit and do all of that kind of stuff, which was not something that either of us had been exposed to before. So it was a huge learning curve, or learning hill, not really a curve, like it was just a hill. So we incorporated in October 2016. We spent almost a year, or September of 2016, spent almost a year developing our curricula. So we went to Explain Pain 3 in Seattle, used the whole curriculum development piece for them, and developed our own curriculum. So we based it off of what we learned there, but we added in much more of like stress biology and lived experience stuff. So we try to share the science through our stories, and then at the retreats themselves, we incorporate the stories of the people who come as well. So we spent a year developing our curriculum, and then had our first retreat in October of last year, 2017, and we've done some workshops and stuff like that too. But it's just about
How's the response?
the response from our first retreat was awesome. We capped it at 7 women because we didn't want it to be too big, and we had one other volunteer staff member. So we had 3 staff, and our volunteer staff member, Tammy Link, is a yoga instructor, but she also lives with pain herself. So she led all of the mindfulness and movement sessions that were incorporated in the retreat. And the response was amazing. Our youngest participant was 22, the oldest was 68. The least amount of time that someone had was just over 3 years. The longest was over 3 decades, the 68-year-old. And everyone, like, just coming together was such a powerful thing.
Now,
like,
this is a research project.
Yeah,
this is something you'd want to.
It would be awesome. We've been in talks with there's practice-based research centers in Colorado. They're all throughout the U.S., but they're where primary care physicians lead research like in their communities. So we've been in talks with one of them that hopefully we'll be able to coordinate. They're going to apply for a grant that will hopefully start leading to some of that, which will be really good for us because we don't have the tools or the mechanisms to be able to track stuff. We're just volunteering at this point. All of the money that we raise through donations and grants goes directly into providing the retreats and the workshops. So we don't even pay ourselves. So it's not like we can bring someone in that could do the research bit too, because we have no money to give to them. So that has to come from someone outside of us. But it's definitely something that we want to do. But the 68-year-old woman who came, she was up on all the pain science. She had read Explain Pain. She had read Explain Pain Supercharged. She was a massage therapist that was a clinician too. And I'm like, what can I possibly, offer her? Because she knows all the same stuff. But she said that being in that environment with other people who were living with pain was intensely relaxing for her. And she felt like that intense relaxation where she just felt comfortable, like in her own skin, allowed her to take in information in a different way.
Very interesting. Very interesting.
And that the way that it was shared through that lived experience lens, because we really try to tie in the relevance of the science to the lived experience and how you can use that knowledge to change your experience. She said it made her understand it in a completely different way, that she was finally able to apply it to herself. So that was so cool. And then we had some people who had no exposure to pain science whatsoever, like none, had zero, like never even heard the term before or knew that it existed. And we had very positive feedback from them as well. So I think that there's really something to that peer-to-peer delivery of education and support and resources that is missing in clinical environments. And I think it could be such a huge asset alongside a clinical environment, like partnering with physical therapy clinics or something like that, where they also have this peer-to-peer support for their patients as well, that can continue to reinforce those messages and that empowerment and that, encouraging one another and having people that understand their experience. Like it's so powerful to know that you're not alone. I'm sure
there's a lot of side questions popping up from what you're telling me right now. One thing that I feel very strongly about is the way that what you've done here is the people actually experiencing living with the pain, taking this initiative together to and also what we see in Swedish healthcare, for example, is not this happening. They are all alone. Out everywhere,
Silent.
and they hopefully they get into this multimodal rehabilitation team where they get pushed with all of these things are good for you, and they get a lot of tools. It doesn't fit them,
right?
Or for hopefully they'll fit at some point, and maybe they'll have something to stick on to their life to hang on to. But there's nothing of this getting in touch with the knowledge and how to use it, to use the tools for yourself. And
how would one do what you spoke about earlier, connecting the science to the lived experience? Can you speak a bit about that?
Yeah, so some cool things that I've done recently, which I think would be really cool, and it reminded me of it during the question and answer session with Tasha, and having a clinician on stage answering a question, and then having a patient answer that same question, and showing how the two relate, but also from the two different perspectives, I think is invaluable. And I was just recently at the Montana Pain Conference in the U.S., and a pain physician, Chris Caldwell, taught a course, he did a lecture on teaching pain science into the patient narrative, and the patient narrative was mine. So I shared the stage with him, and we talked about the science and how to actually apply it to a person, like how a real person actually used that information to change their experience. So I think for both clinicians and patients, that type of thing is so valuable. But I think that should be a part of every professional conference, so that clinicians can even see the value of translating that information to their patients, so they could develop within their own communities and populations a patient educator, a patient advocate that they could then partner with and maybe deliver some public education stuff, or just for the patients at a particular clinic, where then like this successful patient that used this information is going to share their personal story and how it helped. It's such a unique way of translating that information, and I think that it's really important. Like the thing is, though, it's got to be a patient that's been through it and can now reflect back. Like, as I said yesterday, when I was in the worst of my pain, I didn't have any of these insights into that experience. I wasn't able to articulate it in any way. So in the midst of it, you don't see the picture. It's only in looking back that you see how all those things connect and relate. And I think that patients delivering that to other patients is the best way to get that information across.
When you tell other people, maybe in that period of their pain, how do you tell them what changed? Or like, for example, one thing I realized while you were talking about this is the way that they're so low on energy that it's really, really hard, for example, trying to address or let's say the system 2 thinking, the intellectual person, because that person is so pressed down because of other priorities, just getting through the day.
Right.
How do you conceptualize that for people in that moment? Like,
so for us too, the environment, the context was really important too. So for us doing it in a cabin, in the great room of the cabin that had views, beautiful views. So nature itself, I feel, is very healing. And it wasn't a didactic environment at all. We just sat in a circle on couches and chairs. It was very comfortable. People could lay on the floor if they wanted to. They could pace behind the couch if they wanted to. We had blankets and pillows for people to sit on so that they could be in the most comfortable position for themselves. We had coloring books so that people could color, because oftentimes, for me, that was one of my go-tos. Because just focusing on coloring, I wasn't thinking about pain, and you might think that would be distracting from hearing the message, but it actually helps a lot of people to actually hear what's going on. We gave them notebooks that they could doodle in and take notes in. So all of these things, just trying to make it as easy to learn as possible, because if it was in a classroom, if it was in like the conference room we have here, it wouldn't work. Yeah. It wouldn't work if you feel like you're a student learning information. Like, it has to be more conversational and discussion based, and that was how we approached it too. So we would share stories. Beth and I shared our stories, and then we'd kind of introduce like a pain science type topic, and then we would talk about it. I wouldn't just lecture about it. We would talk about it, and I would invite people to share something that this reminded them of their own experience. Like I said, we talked a lot about stress biology, and that seems to relate to people much differently, because stress is more accessible. It's hard to talk about pain, but talking about stress, everyone can relate to stress, and it feels a little less threatening. So we would talk about stress and how much stress affects our physiology, and showing the whole parasympathetic, sympathetic, kind of the fight or flight response and the freeze response, and having descriptors in there of what that looks like that people in pain can relate to. That whole withdrawal, the isolating yourself, the fear, anger, depression, sadness, like all of these different things that can happen. And then the freezing, like the completely not being able to do anything and shutting down, or like what I would consider my meltdowns, when I would just be done and I couldn't do anything at all. They relate to that, and then we show that. I would draw it out on just an easel paper, and then we would show the value of bringing those systems back down, those protective responses and systems back down, and being in, it's like a green zone for us, like safety, comfort, social connection, and in that there are things that we can do ourselves to do that, and then we would just talk about that.
Is that a good gateway to talk about pain later?
Yeah, I think it's, and then, because then after that, then you can talk about the relationship between stress and pain, and it's all the same systems. We're only made up of so much stuff, you know. It's all the same hormones and neurotransmitters, the same brain, the same immune system is working with all of this stuff, and it's all protection from threat. You know, it's all related, and people can really see that connection. So then we could talk about how, like, if anyone has an experience of stress going up and they realize that their pain goes up too, even if it's good stress, like you're going on vacation, that could be a really stressful experience for people living in pain, because travel can be so difficult, especially for me. When I couldn't sit, being on an airplane terrified me, so I didn't go visit my family because they lived 2,000 miles away. I wasn't going to go sit on a plane for 5 hours to go see them. It just seemed so inaccessible and impossible. So just being able to think, and how much my pain would go up before even just going in the car. Like, I wouldn't even be in the car yet. Just thinking about going in the car, my pain would go up. So people can relate to that, and they're like, oh, yes, when I go do this, my pain starts to go up. And then we can talk about how, like, it's just that protective response, because that's a threatening thing. Like, it's a scary, you're worried that pain's going to go up, all of these things. These are the things that we can do to start bringing that back down.
Speaking of those factors, because this is mainly for healthcare professionals, I think we have the biggest issue here. How are we to better conceptualize what are called psychosocial factors?
My question exactly.
In relation to biology. You spoke about this yesterday, but we're recording this now. Can you speak a bit about that?
Well, so one of my biggest frustrations is that I feel like psychosocial is over here and bio is over here, and bio is real, and psychosocial is somehow less real. But our thoughts, our behaviors, our emotions, which are all in that psychosocial realm, our interactions with other people are all underpinned by biology, because we always have our biology with us. Some of the ways that I help people to understand that connection is like anxiety, or like public speaking. For people who have a fear of public speaking, how their physiology actually changes. Their heart starts beating faster. They might start to sweat. They might have butterflies in their stomach. So we talk about those kinds of things. That's worry about being on stage. That's actually affecting the physiology. It's changing your heart rate. It's changing your blood flow. It's changing all of these things. That same exact symptoms and things might happen when you're on a roller coaster too, where it's the exact same physiology changes, but the cause of it is totally different. And for some people, it might relate to terror because they're afraid of roller coasters. For other people, it might be excitement. But the physiological reactions are the same. It's the elevated heart rate, the excitement or nervousness, depending on how it's characterized. So we kind of talk about those things to also share that what we're feeling can be, like, the actual sensations can mean different things in different contexts. And that can start to change our feelings about the things that we feel in our bodies that we relate to pain. Like, for me, I think part of my huge transition has been, because my hip still feels different. My right hip still feels different than my left hip. It's tighter. It still funks and does weird things. It makes weird noises sometimes. And before, that used to be really concerning, and I would worry about it, that I was doing more damage to it. Now, I just think it's weird stuff, and it doesn't hurt anymore. And that perception shift is so valuable and so important, but I think using other ways in to show that our sensations can mean different things, in different contexts, and it's about changing the context and the reactions to those things that is really valuable. And that's why so much of those, like the bringing systems down stuff, is so important for all of that. Like, having a meditation practice was really important for me because it taught me to be less reactive and to, like, more critically assess what I was feeling, not just believe it all the time, like, take a step back and realize, like, what else is going on in my life right now that my pain may be going up, and that it doesn't have anything to do with damage or anything in my hip. Like, the internal hip stuff is exactly the same as it was yesterday. Yeah. Why is my pain going up today, and what can I do about that?
Are there any key things you've noticed in or like these aha experiences from the people that you've been working with now and your own experience that because this is for me like speaking as a clinician. Also, I've had a knee period, 2-year period with I understand all these things because they hurt me so much emotionally, more than my knee actually bothered me.
Right.
But just the fact that making the psychosocial stuff biological and understanding just that, getting to that, and understanding what I love about, for example, explain pain and the key question, the key principles of knowing that pain is multifactorial. To get there really fast, to understand how everything, you have a lot of opportunities to change your pain. What have you seen, like key things to get to that knowledge?
So, like, for me in particular, like, decoupling pain from damage was a big one, but that's a big hurdle to get over for folks because where they feel the pain. I mean, even for me, it was a huge hurdle. I'm like, no, that makes sense. I read all the explained stuff, pain stuff, makes total sense. But my pain is in my hip, and it's totally different. Like, so you go through this like cognitive dissonance, and one of the things that I try to relate to people, like the pain in the knee, we talk about just how our body is a system, and that through the knee is still our immune system and our nervous system. That all of these things are passing through those joints as well, and that our nervous system and our immune system are connected to our brain. And we talk about neurotags and neurons and how they're surrounded by glia, so that there's this constant communication between the nervous system and immune system, so that our thoughts, which are neural impulses too, that are in constant communication with our immune system, are talking to our knee, and that starts to click for people. So the pain can still be in your knee, but be a more systemic, multi-system response and not just tissue damage. I met a guy, so me talking about pain to everyone, I met a guy at the airport who was having knee pain. He was a veteran, so he was in the Army for 10 years. And he was talking about, I actually had met him on a shuttle on the way to the airport first, and he told me that he worked for a nonprofit now. And then he went to sleep. And I had told him I work for a nonprofit in pain and that kind of stuff. And he said, I want to talk to you about, he works with other veterans, about coming in and maybe talking to our veterans about pain stuff. I was like, okay, so I'd given him my contact information. At the airport, he texts me and says, are you on your plane yet? And I said, no. He's like, I'm about to pop 2 Percocet because his knee was bothering him so much. I said, let's talk. Like, where are you? Let's just talk. So we went, and so I just said, tell me your story. Like, tell me what's going on. And so he talked about being a veteran. He was in the Army for 10 years, and all of that, wearing combat boots with rucksacks, just tore up his knee. And so I just said, I'm like, what if it made it stronger? And he looked at me, and he was like, what? I said, what if all of that loading it made it stronger? He's like, I've never thought about it that way before. I'm like, well, maybe we should start thinking about it that way. And so then I just asked him, like, so what is it preventing you from doing? Like, what do you love to do? And he loved bowling. He wants to become a professional bowler now, is his big thing. But for his form, he couldn't get low enough on his right leg where he had the knee pain to have like perfect form. So I had him show it. We're in the waiting area at an airport, and I'm having him go through his whole bowling thing. And he was showing me how low he could go, and that he was afraid to go lower because he was afraid he wouldn't be able to get back up. And so we were talking about doing like his own graded exposure or graded activity at home where he would just get lower and lower and lower. So we just kept talking. He goes, you know what? When I have a drink, I have no problem getting low, and I can get back up and it's fine. I'm like, okay, so we just got to get you to where you're feeling safe and comfortable and disinhibited enough without the alcohol. Yeah. He's like, yeah, because I can't drink on TV when he's the professional bowler. You can't be like doing shots before he bowls. No. So we talked about all this stuff, and we just talked, very briefly about some stuff that he could do to bring his systems down a little bit, and doing that while he's watching bowling on TV at home, just doing some graded exercises where he's getting lower and lower and lower. And I'm like, just, text me in a couple of weeks and let me know how you're doing. So I think that there are ways in, and that way in is always through their story. Yeah. And you can relate the science directly to their story in a way that they want to believe it, and because this is something that is meaningful to them and they want to get to, so they're going to be more invested in.
That's a powerful sentence, I'd say, Because I'm just thinking of, because in an opposite way, my feeling also from my own experience is that there's also somehow a willingness to adapt for example, the biomedical stuff. I want it to be something structural. I want it. That's what I want it to be. In an unhealthy way, which also gets.
That's psychosocial.
Yeah, exactly. But another question, I think we're gonna have to head in soon. But when you've actually gotten to that step, you notice that change in the attitude and with the person. How do you make sure that people, when they realize they open that door and they understand that okay, pain is multifactorial. How do you make sure they don't also take too far-fetched ideas like, okay, am I in pain because I'm supposed to be from childhood trauma or blah blah blah, taking it too
Punishment from God, or
from God, and thinking that I'm not taking too far-fetched things, which might be included, but still make it relevant. Yeah.
And for that, and that's tricky stuff depending on the person and what their belief systems are surrounding that kind of stuff. But I relate so much of it to that this is just it's a human experience. You know, pain and suffering is a human experience that is shared across all humans, and it's everyone's going to have pain or suffer in different ways. And that, you know, good people are in pain and suffer too. That there is no like deciding factor of who's going to get pain, and that it's much more related to all of these contextual factors. And the work of Bruce McEwen and the stress biology stuff and the childhood trauma stuff was really helpful for me in conceptualizing that, especially because I have a high ACE score. Like I had some stuff that I never really thought about until just recently that set me up for chronic pain. But that doesn't mean that it set me up to have pain for the rest of my life. That there are things that we're bioplastic, so those things do change us. You know, they change our physiology, they change our biology. But we still have power to continue changing our biology. It doesn't change until the day we take our last breath. Yeah. You know, so I love hearing how you bring in bioplasticity. Bioplasticity is my favorite concept to relate to patients or people living with pain. I don't have patients. I just talk to people in pain. Because it's powerful. It's so powerful, and it really highlights how valuable getting back to the things that are meaningful to that person are, down to their cells. You know, it's not just a mental thing, but they have to make that shift too because when I first started going back out into nature, when I first went back out with my friends again, my focus was still solely on the pain. I was still, I wasn't present. I wasn't engaged with those things. All I thought about was pain. I was just in different environments. And some of that just takes time. You know, it just takes exposure and time that Mary showed for the pain education stuff, and how at a year there's significant changes in pain. Yeah. So pain levels might not change right away, but life can start to get bigger around it, and then it starts to have this effect later on that pain levels go down. But for me, when I started engaging with my life and started practicing being more present, because it was practice, it took active shifting of my focus to the world around me and from my hip to be able to engage with the things that were going on around me. As my life started to get bigger, I didn't mind so much that I still had the pain, because my life was bigger and it was more enjoyable, and I felt like I was more present with people again after years of being removed from everything. And then by continuing to do that, practicing, re-engaging with the world over and over again, my pain levels eventually started to go down too. But I had to have that idea that it wasn't damage, that I wasn't harming myself with each painful step, because that's so limiting when you think that you're doing harm to yourself if you feel pain.
This brings me to, I think, the question of
I think we might have to actually wrap it up.
Just how do you, for the word acceptance, I hate it and I love it, but a functional view of acceptance for the person in pain, and not accepting it as this is how it's going to be. accepting, for example, this is how it is right now.
Yeah.
How do you tackle that word with people? Or for yourself?
Yeah. Well, so for me, it came to realizing that acceptance just meant accepting my current reality, that this is where I was, that these things had happened and led me up to there, and I couldn't go backwards, that none of us could go backwards, and that was okay, and that by accepting right now didn't mean I was accepting it as my future too. And to me, it was just making space for pain, so there was room for everything else. So there was room for that life around it. So I just made a little bit of space for it. Like, okay, I don't have to fight you. I don't have to battle you. I don't have to struggle with you. I see you. I recognize you. I respect you. But I'm not afraid of you anymore. And if I'm gonna have pain, I'm gonna live my life with pain rather than waiting for the pain to be gone to live my life. Because when you wait for pain to be gone to get back to living, you'll never get back to living.
Cool stuff.
Great way to wrap it up.
Yeah.